Welcome to Mental Health Mini number 20, where we'll talk about delirium. Delirium is a neurocognitive disorder of attention, awareness, and cognition. It is very rapid in development, and it is more common in individuals older than the age of 65, although it can happen in younger individuals as well. Unlike most neurocognitive disorders, delirium is reversible. It's typically treated within 3 to 7 days, but can take up to a month depending on the cause of delirium. Common causes that can cause delirium are things like infection. So if you've ever heard stories of your older patients that have a UTI and suddenly they start hallucinating and they seem disoriented, that would be an example of infection-related delirium. Other illnesses, metabolic disorders, hypoxia, renal and liver failure, head trauma, experience of a seizure, migraines, brain tumor, stroke, nutritional deficiency, pain, burn, heat, surgery, social isolation, emotional stress, substance use, and medications are all common causes of delirium. We also see increased experiences of delirium for patients that are in the ICU or that are hospitalized for an extended period of time. Symptoms of delirium includes difficulty shifting attention, increased distractibility, disorganized thinking, incoherent or pressured speech, tangentiality, impaired reasoning, disorientation, illusions or hallucinations, hypervigilance, stupor or fatigue, agitation, and emotional instability. I especially want to point out the stupor and fatigue because a lot of times people associate delirium with a patient coming in and having all these hyperactive, confused, dangerous behaviors, but we can also see it where the patient is so fatigued that they're almost comatose, and that's another experience of delirium as well. Treatment of delirium, first and foremost, is to eliminate the cause. If they have a medication that's causing delirium, we want to remove that medication. If they have an illness, we want to treat that illness. We also want to minimize any overstimulation, so make sure that our lighting is low, that the sound is nice and quiet. We want to make sure that our clocks and our calendars are large enough for the patient to see. We would want the patient to be kept as close to the nursing station as possible and implement things like fall precautions or a one-to-one for safety. We would also incorporate any interventions that are used for neurocognitive disorders as appropriate that are caused in the mental health mini on neurocognitive disorders. As far as medications go, we can provide them with a second-generation antipsychotic that will help with any disorganized thought content or hallucinations. We can provide them with a benzodiazepine to address any anxiety, an antidepressant, or melatonin or Rosarum for sleep disturbances. And that wraps up our talk on delirium.